Hi, I'm Keith Willet. I'm the Professor of Orthopaedic Trauma Surgery in the University of Oxford, and I'm also the National Clinical Director for Trauma Care for the Department of Health in England. CSC, I've known about CSC through a benefactor that I know in another area, and he has asked me to help him with several projects around the world. And when he asked me to come to CSC several years ago, I eventually found some time back in 2008 for my first visit. I came here, met Jim and the team, and worked out a package to try and help Jim increase the work they could do here, the quality of the work they could do here, and to start off several other projects, and those are now in train. I think CSE is different. It's got a fairly unique role. It is in a developing country, and there are many other NGOs or similar units working. But I think Cambodia's had a particularly difficult time. It has that whole loss of a generation of doctors, nurses, and they therefore don't have a new breed coming through in the same numbers as other countries. It's still not a particularly common place for people to come, and it's certainly not where a lot of people migrate to even end their career. So Jim's a fairly special individual. CSC is doing a very individual job, offering free health care for an enormously needy population. What amazes me about CSC is the patient profile. There's hardly a case that turns up that hasn't been, by all Western standards, just neglected for months or years. I don't think I've seen a patient who has yet presented with a fracture less than 8 weeks old. And many of the operations we're doing are on patients whose fractures are between 3 and perhaps 15 years old. Many of them live with profound deformity and disability, which would just not conceivably be tolerated in most parts of the world, even a lot of other undeveloped countries. And I think that's because of that lost generation. There's just no history of going to a doctor, because doctors for the last 2 or 3 decades just haven't existed. And so, apart from traditional medicine, there hasn't been an option. Okay, so you arrive at CSC, you fight your way through the crowd at the door of patients who are queuing up outside to come in, all stood there in a line, very patient, obvious deformities, just walking past them, wounds, burns, and then you're inside and it's busy, busy, busy. Yesterday I saw 84 patients, as well as doing best part of 10 hours of surgery. So anybody who's looking in here who does couple of joint replacements in a half-day operating list will know that's not a normal day. Okay, so I think the biggest difficulty is, I've been an orthopaedic trauma surgeon as a consultant for 20 years and in practice for over 30 years, and most of the operations and cases I'm doing here I haven't done before. Technically I can work them out, I can innovate, but there is just gross pathology. So tumours here don't present 2 or 3 months down the line with aching and a bit of swelling. They can occupy the whole of a thigh, they can be fungating through. You have major fractures which have been treated by nothing but literally spit and a bandage. So they arrive grossly deformed, with joint stiffness is a massive problem. We've forgotten what fracture stiffness is in the West. Fracture stiffness predominates here. So lots of problems, and then you go to do the surgery and clearly you're asking to do technically very demanding procedures. But in fact a lot of the equipment you have just is not modern. Now fortunately I've got grey hair, been around a long time, and I can make most of the old kit do a lot of things that perhaps a younger surgeon who's used to very advanced kit would be dependent on the advanced kit, whereas perhaps I can be more adaptive. But I think as a young surgeon coming here, you'd find it really challenging. You cannot follow the same sort of protocols because the facilities aren't here. There is blood transfusion, but you can't suddenly get hold of FFP if you have a bleeding problem. You can't suddenly call on a vascular surgeon if you end up going through a vessel taking out a tumour. you're down to a lot of very basic surgical skills. So that's very different. Great support, a lot of energy in the teams, but you are on the back foot most of the time and you will have to make lots of compromises. So mixing metals in plates and screws, it's a necessity. Screws have all been used before, so have the plates. That's what it's like in the developing world. So you just have to, my overall advice is you just have to arrive and reset all the dials for diagnosis, all the dials for investigation, all the dials for your surgery that you can do, and the implants you might have available to you. But you've still got to treat these patients. You can't walk away from them. You're all they've got. I think the best thing to do is to come with a very open mind. Bring some of the old textbooks with you. So some good old versions of Campbell's Operative Orthopedics. Don't choose the modern version, choose something that's 20 years old in a second-hand bookstore. It's probably much more likely to be useful to you. And be prepared to innovate. Bring an anatomy book because most anatomy is very distorted, and just bring some confidence that you know what you're doing. I think this is a fantastic place for junior doctors and medical students to come. They will see more pathology here in a week than they will see in their whole medical undergraduate training, and probably in their whole consultant or medical careers. Everything here is fantastic teaching material. Very busy, so you've got to be prepared to watch, listen, and then go away and read around it. But I think it's an opportunity that people shouldn't miss, and I would strongly recommend it.